Hello, my name is Paul Riley from the scientific marketing team at Diagnostic Astago, and I'd like to welcome you to one of our Lab Week educational webinars from Dr. Ila Singh, who serves as Chief of Laboratory Medicine and Chief of Pathology Informatics at Texas Children's Hospital. She is a professor of pathology and immunology at Baylor College of Medicine. Dr. Singh founded the Clinical Informatics Fellowship Program at Baylor. She has played a pioneering role in advancing laboratory test stewardship, helping ensure that the right test is performed on the right patient at the right time. Dr. Singh has experience both as a basic researcher and a clinical researcher. As principal investigator, she has secured R01, R21, and K08 grants totaling $7 million in direct costs from the NIH and from the Department of Defense, the CDC, and private foundations. Her current research is focused on using machine learning approaches to determine risk stratification, prescriptive analytics, better utilization of healthcare resources, and optimization of treatment protocols. She is the founder of TrueLab, a national initiative to change the names of clinical lab tests to those that are more standardized and easily understood by clinicians. Dr. Singh completed her MD at the University of Bombay and her PhD at Yale University. She served as a Jane Coffin Childs Fellow at Stanford University and completed her clinical pathology residency training at Columbia University Medical Center in New York City. Dr. Singh is dual board certified in clinical pathology and in clinical informatics. I'd like to welcome Dr. Singh to present her webinar now. And at the end of her presentation, if you have any questions, you may put them into the presentation's chat window at any time.
Well, thank you, Paul, for this wonderful introduction. And it is a privilege to be speaking to laboratory professionals for Lab Week. And I thank you for this opportunity to Astago and to you. Today, I'm going to talk about informatics and the modern clinical laboratory. And the subtext of this is how to work with your hospital information technology team, and how to make sure that the interests of the lab and our patients are up at the forefront. So today's goals are to present the role of informatics in modern clinical labs, to discuss the importance of laboratory and central information technology relationship in implementing new tests and optimizing clinical decision support, and a whole lot of other things that we'll be discussing. And then provide successful examples of how to build this relationship and the challenges involved. So pathology and informational services or information technology partnership is a crucial part of getting things done in the informatics realm. So I think of them as two separate bodies in our institution, Pathology Informatics and Information Services. In many institutions, when you undergo a LIS upgrade, there's a strong pull to merge the LIS team with the hospital IS. And a lot of people have succumbed to that. I would say that a strong case needs to be made for keeping these two separate, because there is a whole lot of domain expertise in pathology about testing, about many of the things that I will be discussing today that could get lost if it is taken over by people who do not have that domain knowledge, expertise, in laboratories. However, despite having these two separate things, I think it is really important for these two to work very closely together. And in our institution, it is seen, the pathology-IS relationship is seen as a mono relationship. And it is built on, and that's not always the case. There's often this antagonism between labs and IS. And it is really what has made us gel well, is that there's mutual respect. They know that we know things lab related, and we know that they know other things better than we do. And this good communication really sets us up well. And it gives us access to a whole lot of laboratory data that in many other institutions, I find that people are constantly needing to ask for access to, which in ours, because of this strong relationship, we have easy access to almost everything that we could possibly need. So I'm going to talk today about a new model for lab informatics. And I'm going to touch on what we do well and spend a whole lot of time on what we need to do better. So we more or less do lab information systems and EHRs well. Now, on a given day, you may be completely frustrated by your LIS or by your EHR, but in general, we do a decent job with those. We do a good job with interfaces. You may not like the pricing model of interfaces sometimes when you have multiple analyzers, multiple systems, but technically we do interfaces well. We also gather data for quality improvement quite well. And most places can put out a very good static data report, static dashboard. And of course, we need to have billing and finance data. So we do that fairly okay. But what we need to do better and we need to do well in the modern lab is we need to do more automation. Staffing shortages are not going to go away. And the more we automate, the better our technologists can do things that only they can do. We need to have more accessible operational analytics, interactive dashboards, automated reports. We need to do clinical decision support better, more thoughtfully, in a more useful way. Informatics education from pathology is a very important part of what we should be doing. Customized software. I'm going to spend some time talking about cyber resilience and more standardization. And I'll touch upon, finally, some research on big data, machine learning. What I won't have time to talk about, which will be a really important part of the modern informatics laboratory, is generative AI, large language models, things like ChatGPT, which will become an important part of our fabric in the future. So automation in testing, let's start there. So I am not going to talk about robotic automation. That's obviously important, but I am more interested in the informatics ends of things for today. So auto verification of results. Bill Marquardt's reference cited below is a useful reference even 10 years later. And he says that auto verification should be feasible for 95% of test results. And most labs are at 65%. And 10 years later, that is still the case. Most labs are still at 65%. And it is challenging to do. You need the right software and your automation algorithms. And here's a simple one. You can see that there are many yes-no decisions that the algorithm will follow before a result is auto-verified and released. You need besides the right software, the middleware, LIS, you also need the right team. You need to have a laboratory director with the vision that you need to get automation on board. And you need to have somebody with knowledge, being able to create these algorithms. The simpler the algorithm, the better it is going to be to test them. So that team in various laboratory sections, because the team needs to have domain expertise as well, is really important to get auto verification done. Interactive dashboards and automated reports. So Michael Dallin, our senior programmer, has set up a series of interactive dashboards. And our managers, directors, supervisors can log in and look at data about a variety of tests, almost all tests, in many different ways. So they can look at, this is our quality dashboard, and you can see that there are labeling discrepancies that we're talking about, because 5 sigma is not acceptable to us, or 4.8 sigma. And so You can look at things in different ways. You can look at a bar chart, a grid. You can look by month, by year. You can choose the campus you're interested in. You can look at a specific date period. And you can really see it the way you want to see your data. Some people like box plots. Some people may want to see the specimens by hour in the day and see that during our peak times, we have trouble with maintaining our turnaround time. You can also look at a control chart, a Levy-Jennings, and you can drill down. Each one of these can be drilled down right down to the sample, to the patient, which you can then investigate further what exactly might have happened there. And you can put in your notes about what happened. And of course, you can then aggregate all of that data and say, okay, I want to know about all of the outliers in this time period for this test that had specimen management as an issue. So you can do, whatever you want. Here's a microbiology dashboard, looks at every test in microbiology, from the very, very commonly used SARS-CoV-2 test to the Zika in amniotic fluid, which is very rarely used. And here our manager wanted to look at body fluid culture, and she was afraid that we were taking too long. So she decided to look at every time period, all the way from receipt in the lab to final approval. And you can do that with any test that we perform. We also generated and still continue to generate a whole lot of automated reports that go out to people who may not want to do this interactive dashboard. So this is like a SARS-CoV-2 report that we would send out every morning, pages of it. This is just one panel that shows the incidence, positivity in different hospitals at Texas Children's. And having your own data allows you to think about it and allows you to look at data in a way that might be more useful than if somebody else is presenting the data to you. So here, for example, if you see this pink line goes with the blue line. The blue line is all positives. The pink line is our surveillance data, where we would go and check every 2 weeks a random set of patients in the hospital to look at COVID positivity numbers. And you can see that when we started somewhere around here, when the antigen test came out, and we weren't doing every test that was not being done in one of our hospital or clinics. And a lot of it was being done outside by patients themselves and patients' parents, that these two numbers diverged from each other. And this was probably the more accurate number if you wanted to predict positivity. So you can do a lot with data when you have control over it. At the same time, Pathology Informatics at Texas Children's was sending data, COVID-related data, to a whole bunch of organizations within the hospital: infection control, employee health, hospital operations, and so on. You can see them all here, supply chain, and then to our local public health institutions, to city and state, to FEMA, to CDC. And then also we were sequencing viral genomes, and that was going to GISAID for sequencing, comparing sequences. It's also better communication within the labs that informatics really strengthens. So when I came to Texas Children's, I set up a daily huddle, and this is one of the first huddle formats we had, where we all gathered in a room and we did a quick rundown of what was going on in the lab today and yesterday and what we expected tomorrow. And we wrote it all down on a whiteboard. And it was very successful. It really brought people together for more than what was just discussed on the huddle board. And it led to this division-wide collaboration and ended up spreading to the rest of the department, including anatomic pathology, genomic medicine, etc. What the limitation of this tool was that every Friday, I would take a photo of this huddle board and then erase everything. So any data that we had was unusable next week. We lost all trends, and really nobody was going to go back and look at those photos for anything. So here's our better version 3 huddle board developed by Fahim Ali. And here it's not just a huddle board, but there's data analysis also that's happening. So this is just a portion of the board. You can just keep scrolling down and there's more, but I'll show you just a few key features. So here's the census for different hospitals, and these are viral numbers, outpatients that we draw in the hospital lab. And you can see the trends. You can see the trends over a period of time for the census in different hospitals. You can see trends of viral infection, not just today's infections. You can see, look at our staffing. Here's today's staffing. But then you can look at a 7-day average, a 30-day average, 60-day average, and so on. And certain labs you can see have less than what we would like them to be staffed at. And there are a variety of reasons for that. But this sort of gives you this immediate impression of what is going on in any given section of the laboratory. This looks at the metrics, the turnaround time, volumes, etc. And you can see that here we are green, so all is good. But these are all retrospective looks. You're looking at what happened yesterday and for the past several months. If you want to look at things in real time, you have to go to customized software. And here's one that was developed at Texas Children's by Michael Dowland, Aaron West, and Dr. Greg Buffone. And it's called Electronic Quality Lab. And I don't know of any other custom software that is like this. So if you're listening and you think you have something like this, I would love to hear it. So this is an application for real-time communication in the lab. And communication is grouped into different categories by colors and by time. So you can talk about equipment, patients, staffing. You can look at different periods of time. And the communication can be two ways. It can be the vertical, from the bench to the supervisor to the director and back and forth. Or it can be horizontal to different sections in the lab. It can go from central receiving to microbiology to molecular micro. And so to give you a view of this, there's a bench view for the lab techs. And here we are looking at CSF gram stain order that needs to be completed within, we say, 30 minutes should be when we can finish a gram stain in. And whether we do it or we not, it results in a red or a yellow. And as it's going on, people can see that, this is something that's pending and we need to be on top of it. Supervisors see that, but they also see other things relevant to them, like there's biohazard training going on with that same group. And then administrators and medical directors see even more. They see that there is recalibration of a new lot happening somewhere else in the laboratory, but it may affect this particular metric, and so on. So it allows for aggregation of data. It allows for tracking several issues from one screen. So I can tell you that the benefits of the huddle and EQL have been great for our laboratory. We've seen sustained improvements in turnaround time. And these have been over and above conventional QI cycles. So here's a paper in Archives that we published about this. And here's CSF gram stain again, where this was the baseline. We were taking 47 minutes, and this was the variation. And with successive QI rounds, PDSA cycles, we were able to reduce it a little bit, but the variation still remained quite large. And the huddle and EQL managed to make this a more standardized process. So The problem with customized software is that there's significant developer time to build useful extras. And some of these builds are entirely outside the system. So when there is an LIS change or upgrade, these novel builds need new interfaces and upgrades with new systems. And we tried to actually ask people if it was okay if we just sunset EQL when we went to a new LIS. And the response was overwhelmingly, no, you can't do that because we are using it for many things. So that's something to keep in mind, that as you develop customized software, you also need to have people to maintain it, to upgrade it, to let it grow with your systems. And you therefore need talented developers to be part of your LIS team. Communication and collaborations outside the laboratories. So during COVID, here's another example of helping other departments with complex data needs. So IMPRACT2 is an immunization database. It's decades old, was built for recording other vaccination data, but naturally got co-opted to record COVID data. And the way some of our folks were accessing data was each patient one at a time by putting in the patient's name and date of birth, and then getting their immunization data. And as you can imagine, that takes a lot of time. And one of our laboratory LIS programmers, Yusuf Mru, was able to automatically scrape 500 records per hour so that we could download all of this information on all of our patients at Texas Children's in a relatively quick manner. Going on to clinical decision support for lab test stewardship. So not all tests are as useful as vendors who make the tests might think. So here's a test for metagenomic pathogen sequencing for next-gen sequencing for pathogen identification. And one of them looks at more than 1,700 pathogen targets and determines what pathogen might be involved in this patient's infection. Very useful in certain conditions, like a deep abscess, where a culture is not so useful because the abscess is somewhat locked away from the bloodstream. But unfortunately, the way the tests are done today, results for most cases arrive well after the diagnosis has already been made by traditional methods. And the costs are much greater than traditional microbiological methods. So it's a perfect test for stewardship. By stewardship, I mean somebody ensures that the right test is ordered on the right patient at the right time. And here we have the Microbiology Stewardship Committee, which does this, and we do it through a CDS tool in our electronic medical record. So the process starts with placing a request for the test. And I say this word with some deliberation. It's not an order, because an order is something that you it's somebody's command and you perform it. Here it is a request to do a test, and this request will be very carefully considered. And it usually, this is how it goes. Regardless of what is going to happen to the request, we collect and hold a specimen. That way, this is a specimen before any antibiotic treatment has started, so it's as good a specimen as you're ever going to get. Now it gets reviewed. And this is done by Dr. Denver Niles, who set up this process, who is double boarded in ID and in clinical microbiology. And so he's like the perfect person to talk to the clinician who wants to test and go over the case and the possibilities and what else might be a better test. And so the test is either approved or it's deferred or it's denied. And So I wanted to say that we do have a way to know that there's a hold on the specimen, so we save it. And you can see that it really has an impact. Before the intervention, we were doing 367 tests per year. And after the intervention, in about 11 months, we're doing less than half of, maybe about 40% of the tests that we were doing initially. So let me transition to preparing for an extended downtime in the case of a cyber attack. And this was a project that we started over a year ago. And we decided that we would plan for 4 weeks of downtime. Now, most laboratories do plan for downtime. Usually what we plan for is for 2 or 3 days. Because we're in Texas, we plan for a hurricane, for example. But we had never considered an extended downtime before. And for anybody who is doing this, I want to warn you that it is like peeling the layers of an onion. When you think you have the answer, and you just dig a little bit deeper and you find a better answer or no answer, and you just keep removing till you find something that is workable. So one of the early things we figured out is that communications are a serious problem in case of such events. What we know will not work is our office phones. They're all voice over internet phones. They will not be working. Most of our faxes in the organization are network faxes. They're not hardwired anymore, so they may not work, they will not work. A hospital email won't work. And Microsoft Teams, which I'm using right now for this recording this webinar, will not work because it needs to verify my credentials, and any other software that needs to verify my credentials will not work. What will work are these downtime computers, and we'll talk about that in a little bit. What will work are analog phones that are hardwired, and there's a few of them everywhere. Our cell phones may work, but not always in the basement. And since most laboratories are in the basement, that's something to keep in mind. Apps for communication like Signal or WhatsApp will work because those are private. And many hospitals have a hospital side and a school side. And so we have that. Baylor College of Medicine is our academic partner. And so for the faculty, at least, that will be a good way to communicate with each other, but that doesn't necessarily work with the hospital staff. And then, of course, face-to-face always works, and we have designated rooms and designated whiteboards where we will put messages. So what is a BCA report, a Business Continuity Access Report? So it's a report that the EMR builds and updates at regular intervals. And that interval may be every hour. It can be an interval that you set. And then this report is sent to all these computers that are normally connected to the network, but will be disconnected in the event of a downtime and will be the only places where you can access data. And so this report is current a little before the downtime begins, but as the downtime progresses and you have used the information in that report, you've collected all the samples that are in that report, that report becomes less and less useful. What we learned, an important lesson, and our IS partners were very helpful in working through these, that the default BCA report may or may not be a useful document for your institution. Also, do not assume that the BCA computers will work. They did not, from the gate, work for us. And more to the point, where are the BCA computers? Not everybody knows where they are, especially in the units where they will need to access them, in the laboratories, of course. So we created maps for all of our dozens of laboratories that show where these BCA computers are here in blue, where the red phones are, and where the fax machines are. So here's what our workflow looks like. So a normal workflow is you order the test, or the clinician orders the test. They may use the online pathology catalog to look up the test. The phlebotomist may use the catalog to look up specimen requirements if they're not available right on our EMR. And then we generate lab labels from that. The specimen is collected and it's transported to the lab either using pneumatic tube or couriers. After the cyber attack, if we assume that everything is down, then we will have to rely on that downtime report that I just talked about. We will need an online downtime catalog, which we have now created. It's 1,500 pages for all of the tests that we have, and it lives on these BCA computers. Also, we'll need paper requisitions, and I'll discuss that in a bit. Printing labels is a big challenge. We went with printing manually from Avery labels. And the biggest challenge here is that you don't reuse the same numbers because eventually you will be using these numbers to put those results back into the system. Collecting the specimen will be more or less the same, but transporting it will have to be entirely by couriers. Results reporting, the normal workflow, it goes from the analyzer to our LIS, from there to the EMR to the clinician, and from the patient module to the patients. After the cyber attack, the results will go from the instrument onto a printer, and then a copy will be made and sent either with a courier or by fax, if there is a non-network fax available, to the clinician. And then patients will get their labs by snail mail. And creating new clinical downtime requisitions was also a challenge because one of the things to keep in mind is that you won't be able to do every test that you possibly want to do. So it's important to first cull the tests to what is manageable during a downtime, and then to have these PDFs available on the BCA computers so that anybody can download and print them when they need to. Other documents that do live in our BCAs right now are epidemiology reports and antibiograms. I want to talk about teaching informatics, lab informatics for the next generation. So several years ago, I started the Clinical Informatics Fellowship program here at Baylor College of Medicine. And it is one of the small fraction of informatics fellowship programs that are pathology department based in the country. Most of the other informatics based programs are not in pathology, they're in other departments. And this is, I feel, important for pathologists because so much of the data, some say up to 75% of data in EMRs is lab related, that informaticists know the ins and outs of it really well, and it helps to have a program based in pathology. We also started the citywide clinical informatics grand rounds along with Wesley Long from Houston Methodist Hospital. And we invite a whole variety of physicians and also non-physicians to talk about informatics in here. And along with Dr. Anantana Pragada, I've been hosting the Artificial Intelligence in Healthcare Symposium, which happens every November. And there's a pathology section where last year we talked about large language models, biomarkers in precision oncology, AI-based approach for molecular diagnostics of Mendelian disorders, and multiomics in the NICU for precision neonatology. So if you're interested in this, again, drop me an email. And when we have information ready for this year's program, I'll include you. Research and informatics. So big data. We have so much data in the laboratory side that it's important that we use it to do our studies. And here's one looking at thousands of pediatric patients and determining that instead of testing people for hundreds of different allergens, you can, using clustering to help us, start out with a very small panel of allergens and then work from there. Here's another really big data study. So we examined, together with Dave Smart and Jeff Schreier, we examined more than 1 billion billing records from 232 million of the US population. That's a significant chunk of the US population. And we found that 7 to 51% of tests exceeded recommended frequencies. And there was some egregious overuse, like hemoglobin A1C or PSA was ordered every week on a small fraction of patients. And we looked at 4 commonly used tests, and just for those 4, a conservative direct cost estimate was more than 350 million. And if you extrapolate that to all laboratory tests, the excess use comes to a few $billion, billion with a B. And it's really in the labs that we can do those sorts of studies. Here with my 2 collaborators, Devika Subramaniam, who is a computer scientist at Rice, and Rana Sonabend, who is an endocrinologist here at Texas Children's, we have made a machine learning model that can predict which patient with with type 1 diabetes is likely to get diabetic ketoacidosis. And we can make that prediction just from features in the EMR. And the model has an AUC area under the curve of 0.8 and an FN score of close to 0.8 also. And it's an explainable model, and we can integrate it into clinical workflows in the future. And that will help tell which patients need more resources. They may need more interventions from social workers, from physicians, from pharmacists, and which others are doing quite well and don't need additional resources. Finally, many of you may know that I am really passionate about standardization, especially when it comes to lab test names. And I want to tell you about TrueLab, which is, before we go there, I think many in this audience will already know that lab test names are not standardized. There are problems between what we think a test is and what a clinician who uses it thinks it is. And so there are 2 commonly used tests for vitamin D, and the wrong vitamin D test is ordered more than a third of the time. And it's because these tests are so complicated in their names, 25-hydroxy vitamin D and 125-dihydroxy vitamin D. It's difficult to keep them straight. Here is from the VA system, where there are over 60 test names for the VA in the VA alone. And I have to preface this by saying that this is not only restricted to the VA. If we look at any of our laboratory systems, we will find the same variety of names for tests. So you can see this more than 60 names for albumin, and you can see that we don't have a good way to deprecate tests either. So you can see how we call them Z-albumin or ZZ-albumin or ZZZ-albumin not in use. And this is, I think you look at any LIS in the world and you will see this. So why do we have this problem? There are more than 4,000 lab tests, and test names are chosen without consulting with clinicians, without a style guide, and certainly without consulting other institutions about what they call test. So TrueLab is the initiative that we started to generate standardized names for lab tests, generate a consensus guideline, and promote the adoption and implementation of these. And we're going about this in a very scientific way by surveying many thousands of clinicians for their preferences in test names and their understanding of them. And these are all of the people involved in TrueLab. You can see that there are many professional organizations that you will recognize. There are EMR and LIS and terminology companies, reference labs, LOINC. There's instrumentation makers, other clinical pathologists and scientists. And then there are federal liaisons who I'm grateful come to each of our meetings, and we are funded by the CDC for our efforts. And we also have international partners that we learned a lot from when we initially started our project. And it's good to just note that they have these same problems that we do as well. We're not unique. If you want to learn more about TrueLab, it's a recent podcast on LabMind that you might find interesting. It's less than 20 minutes, so you can hear it in 2x speed. Finally, using informatics to recognize laboratory professionals. So every Friday in the daily huddle, we acknowledge individuals that have gone above and beyond their usual work. And every Friday evening, I would manually put together their pictures and send out an email with all of that. Sometimes that took a while, and it got really late on a Friday night before I could get that email out. Until Karen Prince, our amazing graphic designer, automated a form. So using Adobe InDesign and Acrobat, she automated a form which produced an output that I don't need to edit too much. I still end up editing it, but it comes out with drawing all the pictures and everything in place. And we are able to acknowledge people on every Friday, first in person in the huddle, and then by email to the entire department, which I think is really important to do that, because our staff goes really out of the way to do the amazing job that they do. So this is what I have, and I don't know if there will be an opportunity for questions after this, and I'm happy to take that. And if not, then I thank you all very much for your attention.